Bruce Arrell's my name. I'm a professor of general practice at the University of Auckland, and the title of this talk is Depression, the Evidence Base for the First Visit. This was prepared with my colleagues Dr. Wing Chin from Hong Kong and Professor Chris Dorick from Liverpool. The English version of this is available on the Wonka website, and at this point it's been translated into Arabic, Mandarin and Portuguese. So what are the psychological issues in primary care? Well, this is data from New Zealand, from general practice waiting rooms in Wellington, going back to 2003, and sort of the most recent stuff. 35.7% of patients have a 12-month prevalence of a mental disorder. That is at a DSM-4 level of severity. So there's certainly something going on for those people. From our own work, we looked at patients in the waiting room, over 2,000 of them, and the PHQ-9 score greater than 9, which is moderate levels of mood, 12.9% over the previous 2 weeks. And one of the things I say when I'm teaching medical students or nursing students is that treating patients with depression can be very satisfying. It's fantastic to see somebody who's very low and withdrawn evolve into somebody who's joined the human race again and got back into life. So it's something to embrace and accept the challenge. So in primary care, the epidemiology is quite interesting. A lot of my students think that it's actually older people who have depression and anxiety, and that's not the case in society as it currently is. And these figures, they're from New Zealand again, but actually they're transferable to the world. Actually, older people have low levels of depression. It's the young people, 22.6% of men there and 33.9% of women. Men tend to have more substance abuse problems. Women have more mood and anxiety problems. And this is shown internationally. The data here, the top 5 there are from one study, and the New Zealand data is from a separate study, but all fairly high levels of depression there. Japan's probably the only outlier. Now, maybe that the questionnaire didn't translate into Japanese. The Japanese have a high suicide rate, but only a 3% level of depression. So one needs to take that into account. So how does depression present in primary care? It's unusual for a patient to turn up and say, I'm depressed or anxious and I want to have help. Generally, they present with somatic symptoms: chest pain, head pain, back pain, leg pain, abdominal pain. And interestingly, 11% deny psychological issues. So the challenge for the primary care clinician is to get from the physical to mental health. And remember that a patient who is truly depressed will have the same quality of life as somebody on renal dialysis. So they'll be feeling very sick, and naturally we want to have a lot of investigations and things done for them. You can diagnose depression, as I say, through the back door by asking the physical questions: sleep, concentration, energy, interest, appetite, moving quickly or slowly. If they're all negative, they're probably unlikely to be depressed. If they're positive, then you might want to move into the guilt question, the mood question, the enjoyment question, and any suicidal thoughts. In terms of converting from the physical health to the mental health, one of the important things in primary care is to raise the possibility. For example, a patient coming in with fatigue, it's important at the beginning to say, well, we need to look at the physical causes for this and any psychological or social causes, so that you're not backed into a corner when the physical turns out to have nothing. This can be stressful sometimes, and occasionally patients will complain. Occasionally patients will say, you're saying it's all in my head, aren't you, doctor? And you have to say, no, I'm just trying to be thorough here. Nowadays, I would do a PHQ-9 questionnaire to check their mood status. This is a depression inventory, which gives a mood level, doesn't actually give a diagnosis of depression. And I have to say, I find that once a patient has filled that in, they tend to own it as they've filled it in. Or I'm just getting better at explaining depression to patients. So why don't clinicians make diagnosis of depression? Well, there's a number of reasons here, and this is again based on work from Wellington, from Tony Dowell's unit there. Some GPs in this case are afraid of Pandora's box. Now that's interesting because hope is what lies at the bottom of Pandora's box. So I think that's a nice way to reframe how we see Pandora's box. And I think if your clinical modus operandi is to avoid the psychosocial, then I think the clinician would need to look at their practice. There's the issue of stigma and insurance labelling. So they're real issues, and I'll talk about an alternative for that. There's the low energy of the clinician, and I think the clinician needs to look at what's going on for them. Not liking mental health is an interesting one. I mean, mental health is a very big part of primary care. If you're a doctor, you may have well been trained to deal with the physical first. The problem with going down the physical route is if you find nothing, then you have to raise the issue of a psychological or a social issue. And of course, that may be a bit of a shock to the patient. And it may be that the clinician is unskilled in raising mental health issues. Here's a lovely quote from Glenn Cahoon, who's the GP poet based in the southern part of the North Island of New Zealand. I saw a young woman for a repeat prescription. Her story was so large, I knew not to ask about it in the morning when the day is fragile with need. And I'm sure we've all had that experience when we're not feeling very energetic ourselves and the patient's story is overwhelming. But again, I think this should be an exception rather than the rule, ideally. So there are a couple of good questions you can use to rule out depression. Have you felt depressed, down or hopeless for all or most of the past month? And have you lost interest and pleasure in all or most activities over the past month? Now this has a good sensitivity, meaning most people with depression will have this. So if they don't say yes to one or both of those questions, it's a pretty good rule out. And for example, with the fatigued patient, you might want to go down a biomedical route first of all in that situation. If they say yes to one or two of the questions, then that could be a false positive and you need to ask more questions. Then I would do a PHQ-9 or a HADS, which is the Hospital Anxiety and Depression Scale, or a BDI, the Beck Depression Inventory. Remember, there's a payment required for the Beck Depression Inventory and there's none for the HADS or the PHQ-9. A patient who gets a score of 12 or more is at a level when you want to offer active treatment. Now, active treatment means non-drug first unless the context differs. It doesn't mean offering medication first up. So this is based on some work that we did. 2,642 patients were screened in the waiting room with a PHQ-9, and the column on the left has the PHQ-9 scores: mild 5 to 9, moderate 10 to 14, moderate to severe 15 to 19, severe 20 to 27. In the middle column is the proportion of patients who were depressed on a computerized gold standard. And on the right-hand column are patients who were not depressed on the computerized gold standard. Now, if you just look at the bottom line there, you can see for severe 20 to 27, of those who were depressed, 1.4% of them were in that range. But there was a number of people who had very high scores who were not depressed. So 0.4% of people. As you go down the severity scale, you're going to get more and more likely to get people who are not depressed. But what's important about this is that most patients with depression in primary care are in the mild to moderate range, and that becomes quite important later in this talk. The other take-home message from this slide is that a high PHQ-9 score is not the same as a patient having depression. They're more likely to have a depression, but you can't make a diagnosis. So what's the value of a diagnosis of depression in primary care? Well, in my experience, just about every patient I see is there's an overlap with depression and anxiety. And there's a bit of a move to using the term common mental disorder or mixed anxiety and depression. In the acceptance and commitment therapy model, the term stuck is used, and this is what's called a transdiagnostic label. And for those who are worried about labeling for later insurance things, then stuck is quite a good term. And you'll start seeing more and more studies using transdiagnostic therapies for anxiety, for example. So the world is coming back to a common label for the diagnosis. What's the value of a diagnosis? Well, essentially the treatments for depression and anxiety are the same. And in the primary care situation, I would argue that it's perhaps better to spend more time on therapy than it is on worrying about getting a precise diagnosis. So in terms of treating patients with depression or distress, 60% of patients resolve in 1 year. And in my experience and in the experience from the research is that most patients will have a lower PHQ-9 score at the next visit. That's because they've had a discussion of symptoms. They've experienced the doctor as the drug, as Michael Barlant would have said. These days we would say the clinician as the drug. The clinician may be a nurse. And what that implies is the therapeutic power of the role of the health professional in talking to the patient. And of course, a lot of things happen in that first consultation. There's reframing, there's normalization, there's hope given and support. And if nothing else, it may just be regression to the mean. So you have a high value of a PHQ-9 at your first visit, like you might have a high value of a blood pressure. The next time, it's likely to be lower. That's just a statistical reality of the biological world. So in terms of treating depression and anxiety, the NICE guidelines, the National Institute of Clinical Evidence from the UK, suggest that at lower levels of severity, that non-drug therapies be used. This would include CBT and computerized CBT, exercise, including yoga and stretching, behavioral activation, which is very important because people start to restrict their life when they get depressed or anxious and they need to open up their lives again. And then just simple problem solving. A patient who's distressed may not be able to see solutions to the problems in their life, and the clinician is able to help them with that. So should we give drugs at the first visit? One of the best bits of advice I was given some years ago by a colleague was that he rarely gave antidepressants at the first visit. And I have to say I've followed that, and I really haven't come to any harm by doing that, nor have my patients. Now, there's an absence of evidence. There's no trials of randomizing somebody to a drug first up and then just usual care. But just remember, the majority of primary care patients are in the mild to moderate range, and many of those who are severe will become mild to moderate. So I would suggest trying the non-drug therapy first. NICE recommends trying drugs only if there's a past history of moderate to severe depression persisting or lower symptoms that have had a duration of 2 or more years. There's some trial work going on at the moment examining these two issues. So based on work from Fournier, which was an individual patient meta-analysis, drugs appear to work best for those with severe depression. Now this work has been challenged, so it's controversial, but it makes sense in terms of other things we do in physical health, blood pressure, cholesterol for heart disease. As you can see here, the level of depression is in the left-hand column, mild, moderate, severe, very severe. The active drug effect is about 6% in the mild to moderate range. In the severe range, it's about 9%, and in the very severe, it's about 25%. The placebo control rate is 47%, 47%, and it drops down in the severe to 30%, which may be indicating that very severe depression is a more biochemical issue. Now, the important thing about this is that the middle column there is actually the active drug effect minus the placebo effect. So that the actual drug effect in the drug arm is actually 53%, but when the placebo is 47%, you would say there's a 6% difference. So you can see that for mild to moderate depression, and even at the severe level, most of the effect is placebo. In the mild to moderate, it's almost 8 times more likely to be a placebo response if your patient gets better. And even in the very severe, it's about 1 to 1. And I'm going to show you some information from our own review of primary care that active drug effect is probably an overestimate. This is the funnel plot from the systematic review we did on the antidepressants in primary care. This is the funnel plot. On the left-hand side, you've got the size of studies. The dashed line shows above that is studies with 150 people or more, and below that is 150 people or more. And there's a circle there saying small studies showing no benefit. There are none. There are only small studies on the right-hand side which show a benefit. There's 4 there. The big studies all cluster around the effect size point, which you can see at the top of the page there. So why is there an absence of small studies showing no benefit? Well, if you're involved in research and you do a small study which shows no benefit, it's very hard to get that study published. Whereas if you have a small study and it shows a benefit, it is somewhat easier to get that published. So those 4 studies on the right-hand side there that are small and show a benefit have been published. And if you go back to the left-hand side there, what's happened to those studies? Well, if I'd done a randomized trial, I probably wouldn't have been able to get it published, so it would be languishing in the bottom drawer of my desk or in an old file on my computer, or it will be in the pharmaceutical company's file unpublished. So this is what causes publication bias, basically. This is some work from Irving Kirsch, who's now based in Harvard. He looked at all the studies from the FDA. So these days you have to register, if you want to get a drug funded, you have to get it registered with the FDA. So on the left-hand side of the column of the graph there, it shows the benefit from antidepressants, and on the bottom scale there is severity. And the red line there is showing antidepressant drug effect, and the dashed line is placebo. And you can see at the lower levels of severity, there is no difference between drug and placebo. And the curves only diverge when you get up to the very severe. And you can see the control group dropping down there. There's less response in the control group as you get more severe. So this would suggest that in the earlier graph that it may even be an overestimate, possibly due to publication bias. So this data gets around publication bias. Now this work has been criticised as well, so there's lots of debate in the literature about how valid this is. An article in The Guardian pointed out that 50% of trials are not published. It's very hard to get negative trials published. So as a researcher, I have a number of trials that have never been published. It's just too difficult to get them published. So what are the harms of the drugs? Well, they medicalise the condition. The patient thinks it's taking the medication that's made them feel better, when in fact they might have made some changes in their life. They've been given some hope, a whole lot of things. The placebo effect is 8 to 3 times greater. The patient credits the drug, not themselves. There's the risk of adverse effects, and there's the risk of overdose. I was working in Canada in the 1980s, and I saw a lady late in the afternoon with depression, and at that point we could only prescribe tricyclic antidepressants. And I asked her if she was suicidal, and she said no. At 8 o'clock the next morning, I was called to our local hospital, which the practice ran in this small town, and there was the lady. She'd taken one of my pills in an overdose. So I then had to put a tube down her stomach, which was what was done in those days, and wash those pills out of her stomach. And I asked her afterwards why she had taken the pills, because I said, well, you didn't seem to be suicidal the day before. And she said, no, I wasn't. But I went home and my husband beat me up, and I decided life wasn't worth living. So I had literally handed her a loaded gun and given her the means to kill herself with. Fortunately, she didn't. There's some evidence that antidepressants increase suicidal thoughts in teenagers, not actual suicide, but suicidality. Finally, they can be difficult to stop. There's the serotonin syndrome, which is the extreme version of that, where the patient has to restart the medication. But people often get minor withdrawal symptoms, sweating, anxiety coming back, and they think it's the symptoms of their mood or depression or anxiety coming back, and so they won't stop taking them. And there's an international trend to people going on to long-term antidepressants. When do the drugs work? Well, I think we can say they work at the severe end of depression. The trick is how to recognize this. One way I would say is a patient with a high PHQ-9 that persists or goes up rather than down, which is fairly unusual in my experience, but it does happen. The patient just not getting better, score saying the same. Maybe that they've had previous episodes, and if they've been serious episodes, I would be more inclined to give an antidepressant. And 12% of Kiwis, which is the nickname for New Zealanders, are on antidepressants. Probably only 3% of them are getting a chemical benefit based on the work that I presented in the previous slides. So most people are getting either no benefit or just adverse effects, and will have difficulty in stopping them if they ever worked in the first place. So they may not have worked in the first place, and then they have trouble getting off them, and then they're taking them for the rest of their life. So when should we follow up? There's no trial evidence on this, but there's a wonderful article called An Insider's Guide to Depression by a British GP called Kay McCall, who suffered from depression herself. And she says, "See us frequently at first. A week is a long time in a Dali landscape. 3 weeks are almost unimaginable." So I always see my patients within a week. I met a GP recently who actually phones her patients up within that week. Very powerful having a phone call. And this is what else helps. So a nurse phone call in a randomized trial, patients were all on antidepressant medication, 1 to 2 phone calls a week for just 5 minutes in the first couple of weeks, and then decreasing up to week 16, asking, are you taking medication? How are you doing? Are you doing the things you said you would? Numbers needed to treat were 5 at 6 months. That's a 20% difference. That's better than antidepressants for mild or moderate depression, and up there with the effect at severe depression. So telephone calls are a very effective adjunct to treatment. So the take-home message here is that patients present with physical symptoms rather than symptoms of mood or anxiety, and that creates a challenge for the primary care clinician. At the second visit, there's usually some improvement. And I would suggest that we avoid drugs at the first visit and talk first, and have some faith in the value of us communicating with the patient at that first visit. And remember, there's a big placebo response if you are going to give drugs. It's important to consider using a telephone if you have access to telephones in your service. And this is one thing I like to say to our trainees, that helping depression, a patient with depression, can be very satisfying.